evening to all of you who have logged in today. And on behalf of the Physician Research Foundation wing of the Association of Physicians of India, it is my proud privilege to welcome you all for this launch meeting of the Heart Attack Management Center course, which has been started under the aegis of the Association of Physicians of India. In fact, this is the fourth year in succession that we have been able to do it with academic grants from Hamcc Pharmaceuticals. And every year we used to have live sessions. And generally, we have been following a module with four sessions each time. This time, we did a little bit of a change. We thought we will have recorded lectures, and physicians from across the country can then listen to these talks. What we have done in addition to the talks is that we have put a questionnaire at the end of each talk, and once you will answer 75% of these questions correctly, you will be certified as a Center for Management of Heart Attack. I must tell you and be very thankful to all the office bearers of API, ICP, and PRF for their blessings for this project. And I am told that around 700 physicians from across the country are going to be doing this course over a period of time. And we have excellent, I have listened to each and every talk. We have excellent 16 talks in total, which are divided into four modules. The first module talks about the methods that you will use to diagnose acute myocardial infarction, history of chest pain, how to understand, ECG, how to interpret, and then non-electrocardiographic methods for diagnosing. We have Dr. Uday Jadhav, who is going to speak, who has given a lecture on acute chest pain, various types of chest pain, and how to interpret it correctly as coronary ischemic pain. Dr. Rajiv Agarwal speaks on clinical utility of ECG. Dr. Chenniyappan, who is an expert on ECG localization, and my dear friend Debabrata Roy, an expert in echocardiography, biomarkers. He speaks on non-ECG. So this is the first module. Some of the experts who have given talks are available with us today, and I will first request them actually to give us their thoughts on their talk. But before we do that, I will request our president of the API, Dr. Jyotirmay Paul, who is a very busy physician, to give his blessings for this program, which we are formally launching today, and then physicians will be using and will be attending some of these talks. So over to Dr. Jyotirmay Paul for his blessings as president of the Association of Physicians of India.
Good evening. I am very happy and congratulate Dr. Gurpreet Singh Wonder, our past president API and immediate past director PRF, Dr. Muruganathan, director PRF, to take such a beautiful initiative to educate and update of the all physicians on the subject that is acute myocardial infarction. I work in a government hospital, government medical college in Calcutta. Basic norms is acute myocardial infarction never admit directly in a cardiology ward. It is basically admitted through emergency to medicine ward, even not in ICU. It is the duty of the intern, house staff, postgraduate trainee, resident medical officer, senior resident to give the initial basic management, particularly thrombolysis. Unless and until there happens some complication or intervention is required, this patient will be treated in the general medicine. And also, most of the time, even if patient requires some CCU or some cardiology, many times unfortunately, patient do not get the beds in cardiology due to scarcity. So physicians must be very much trained about the management of acute myocardial infarction. And due to the increased prevalence of non-communicable diseases, particularly the hypertension, diabetes, obesity, metabolic syndrome, Now the incidence of coronary event is increasing in India, and thrombolysis nowadays is available in every corner of the country. And now it has become a basic medicine in the Department of Medicine. It is not a specialized job. So I think this is an excellent initiative by the PRF, the research wing of API, to educate the residents, physicians regarding the how to diagnose the MI. Particularly many times we miss the ECG interpretation, particularly the interpretation on the AVR. This is often overlooked by the physician. So basic in ECG interpretation, and when patient will come to the physician, what is the duty, what is the first management, what is the basic management, how we can save the myocardium. This will be, they will teach expert like Dr. M. K. Das, Dr. Devbrata Roy, Dr. Wonder, all will teach in 4 modules, and I am sure the physician and student will be much benefited. I wish such initiative, and I hope PRF will take such more and more initiative to educate and update the Indian doctors so that they can treat the mankind in the best possible way. Thank you. Over to Dr. Wonder.
Thank you, President Sir, for your blessings as always for any academic exercise. And we assure you that PRF now under the leadership of Dr. Muruganathan will undertake this project. And just as you said, physicians in tertiary care setups must treat these patients effectively along with cardiologists. Similarly, most of our patients actually go to centers where cardiac setups are not available, and this hub and spoke model for treatment of acute myocardial infarction patients in a collective manner is ultimately the goal to save larger number of lives. So before I go on to the experts, I'll request Dr. Muruganathan, our present president, director of the PRF, to give his blessings.
Thank you, Wanderji. Thank you, Dr. Josmai Paul. I completely agree with Josmai Paul, whatever he said about the heart attack, CME. And then this is not only academic, it only also makes the physicians to face any challenges also, and then the morbidity and the mortality of the myocardial infarction and heart attack will be reduced. So it has got both academic value as well as life-saving value. I think we will have a lot of such innovative programs. At the end of the programs, we'll also make sure these physicians join us in doing some research. Already we are also exploring the possibility of how AI can interrupt ECG and how we can support the periphery physicians also. I think with all your expert comments and opinions, we'll make the module in a much better way, which is very, very practical, which is very useful. Thank you, Wonder. We will continue our good work, and we also want you to continue your role as the guide for this program. Over to you, Wonder. Thank you.
Thank you. And for the delegates who are going to be registering for this Heart Attack Management Center course, we are lucky actually 2 of the experts who have delivered lectures in the diagnosis of STEMI are with us today. I'll first request Dr. Rajiv Agarwal from Meerut. He's a close friend and an excellent orator. ECG, he's spoken on ECG for diagnosis of acute MI. Dr. Rajiv Agarwal, please.
Thank you, Doctor. Thank you, Dr. Wander. And my description should have been, he is a friend, not an old friend, because that implies age on both of us. So let me start. And there are so many people whom I look forward to listen to and understand, but I strongly feel the diagnosis of acute MI is visual. And those visual patterns, majority of our patient, 85–90% of our patient, they come with those classical ECGs. Leave aside those patients who have atypical ECGs, those who have localization value. I often say MI is myocardial infarction and is a myocardial infarction. It is far more important to diagnose myocardial infarction than to localize the vessel, because the treatment algorithms are same. It was a theoretical exercise pre-angiography era, that which is the artery. Today, if you have an MI established clinically, on top of it supported by electrocardiography, you are done 2 out of 3. And you have 2 algorithms. One is the medical algorithm, another is the invasive algorithm. In both algorithms, we can go very, very effectively either way. So I am a very strong believer that primary care physicians should be taught visual classical patterns of MI. And in my talk, I have tried to give so many visuals, how they mean to a common man. And common thing is squarish is the ECG, more difficult is the patient. Higher the ECG amplitude, worse is the prognosis, or is likely to be a life-threatening, what is described as tombstone appearance. So with all these words, I strongly feel the primary care physician should be coherent with a visual diagnosis of acute MI and then clinical description. These 2 things make it very, very easy. And then one can decide whether it is medical arm or an invasive arm, depending upon the facilities. And the key to success, all of us are brought up with, is the time. Earlier you take action, better it is. In first hour, if you are handling, even in a non-invasive setup, a medical arm, it does wonders. Thank you very much.
You, Rajiv. Obviously, as you have rightly pointed out, the effort is that physicians across the country shed this fear of diagnosis of STEMI, and this is what the first few lectures are going to actually cover. Diagnosis of STEMI is largely a diagnosis of ECG, and it's a very simple, actually, way that you can diagnose. Most physicians already know, and as you said, equal respect for the pharmacological as well as for the invasive methods. Time is the biggest factor, and the faster and earlier you do an ECG, more confidently you interpret. And depending upon wherever you are sitting, actually, in the periphery or in one of the tertiary care centers, you can help these patients depending on the algorithms that have subsequent lectures have given. But before we go on to management, we are fortunate, Dr. Dev.
Wonder,
Yeah, please.
just 1 second, 30
Please.
seconds. The guideline described doing a ECG within 10 minutes of first contact. This is class 1A indication. So let us bring speed in our paramedics, in clinicians, that it is fire at home. Be quick, be quick. Time is important. It's not like the patient is getting ECG in 1 hour. Thank you very much.
Early ECG, and depending on what facility you have, if you don't have thrombolysis facility, send to the nearest thrombolysis enabled center. In case the time to go to reach a PCI feasible center is large or more than 30 minutes, then obviously you like to send your patient to a thrombolytic facility. But it's not always that the diagnosis is so clear before you with the ECG. We all know painless infarcts, atypical pains, delays for patients to reach hospital are always there. And we are very lucky Dr. Debabrata Roy is with us. He has talked about actually the non-ECG biomarkers, other methods to diagnose STEMI and STEMI. So I'll request Dr. Debabrata Roy to please speak a little bit about his talk, his thoughts on this program, and his thoughts on management of STEMI by physicians across the country. Dr. Debabrata Roy, please.
Yeah, thank you very much, sir. And I'm proud to be part of this wonderful initiative. As already stated by you and now my previous speaker, it is of prime importance to involve the primary physicians in the diagnosis of STEMI. ECG definitely plays a very important role in its diagnosis. However, in some cases, ECG may not give you any clue. And there is the importance of the biomarkers and other investigation modalities like echocardiography. In fact, if you look at the diagnostic criteria of myocardial infarction, along with the ECG changes and the symptom of chest pain, you need to have a rise or fall in high sensory troponin I with one value at least above the 99th percentile of the upper reference limit, and documentation of regional wall motion abnormality in the echo. I know it is difficult to get the facility of echocardiography always at the primary care level. However, I believe that troponin testing, especially the troponin T kit testing, can be done in most of the places if proper initiative is taken. What is important to note that the biomarkers and other diagnostic modality, especially echo, they don't only play an important role in diagnosis, but in prognostication as well. In fact, echo can give you a clear idea on the wall motion abnormality, the ejection fraction, and any complications associated with myocardial infarction, like ventricular septal defect, like cardiac rupture, like pseudoaneurysm. So these are very important mechanical complications which require immediate attention. And as Sir has already stated, and Dr. Jyotirmoy Pal, President of API, he has also emphasized that API has taken an initiative of applying artificial intelligence for the interpretation of ECG. And I would request them to consider whether this artificial intelligence can be applied to interpretation of echo images as well, which can be captured by point of care tests. Thank you.
Thank you, sir, for highlighting not only the value of non-electrocardiographic methods for diagnosis, but also for prognostication of these patients. And a lot of centers which manage patients of STEMI and STEMI, they have echocardiograms in the emergency rooms so as to aid in the diagnosis. And as you beautifully said, complications of STEMI are equally important to be picked up early besides the prognostication. So these 4 talks in the first module, delegates, you will have actually ample exposure to how to interpret the chest pain, what chest pain parameters indicate that it could be ischemic and non-ischemic. Dr. Uday Jadhav has covered this. And as Rajiv and Dr. Cheniappan have covered the ECG, and Dr. Debabrata Rao, thank you to each one of you for having participated and for sparing your very valuable time today. What we have done is we have put 7 or 8 questions actually. Myself and my team in my institution have put from the lectures that have been delivered by these experts. We have put 6 or 7 MCQ questions out of them. So as attendees, you can answer those questions and see. You can in fact go back to some of these talks if you have problems with it. Well, the second module will talk on the management of STEMI, thrombolysis, distinguishing between STEMI and NSTEMI, pre-hospital care, and also associated drugs along with fibrinolytic therapy. So I'm thankful to Sandeep Bansal for having spared his time. We all know he's an excellent clinician, a great teacher, with his background from Punjab, but now heading one of the prominent cardiology department in Delhi. So
He's a UP
Sandeep,
boy.
will you?
He is a UP boy. Don't make him
No, he's
Punjab
a
boy.
Punjabi. Come on. So over to Sandeep Bansal for.
Thank you, sir. I'm extremely grateful to Dr. Wander sir and Dr. Rajiv Agrawal, my very prestigious seniors. So my talk is basically on the fibrinolytic therapy. See, we need to understand that there was an era in management of myocardial infarction where it was said to be a phase of masterly inactivity. We did nothing except for giving rest. And thrombolysis, which started somewhere in 1981 with the GC trial, wherein streptokinase was used as a lytic agent, was the first definitive management as we know. We are also aware that while the treatment of choice for the management of ST elevation MI is a timely PCI, however, as has been highlighted, there are studies to show that if there is a more than or equal to 120 minutes delay, then there is absolutely no from the first medical contact, if there is a more than 120 minutes delay, then the benefit of PCI is lost. So what is important is reperfuse these patients using whatever modality you have. And if you don't have PCI at hand, by giving thrombolytic therapy, you are actually able to buy some time, because then within 24 hours of having done the thrombolysis, you can actually go ahead and do an angiogram in these patients and open up their arteries if they are still closed. One of the methods that is called the pharmacoinvasive therapy. In a large number of people, which are, in large number of places which are very far off and do not yet have angioplasty facilities or cath lab facilities, the reperfusion therapy with fibrinolysis can be a standalone therapy also. So, two important roles as a standalone and as a part of the pharmacoinvasive therapy. We also need to understand, and you'd be able to do that, to distinguish between fibrin specific and fibrin non-specific lytics. We'll also be discussing in my talk the difference between these, and also what are the features of an ideal thrombolytic therapy. So ideally, it should be a fibrin specific therapy. It should be able to be given as a bolus, preferably a single bolus. It should have, a quick reperfusion, and it should cause a TIMI-3 perfusion, and there should be a reduction in mortality also. And fortunately, we have lytics available. I have been extremely lucky that for over 15 years that I have headed cardiology, we have been able to convince the government of India to have tenecteplase on board, which is the major single bolus thrombolytic. And of course, we should be aware of the side effects of fibrinolysis, the contra.
By mistake, you went on mute, Dr. Bansal.
Please unmute yourself.
Yeah. So, as I was saying, given in the correct manner and in the correct hands, this is a wonderful tool, and I'm sure we'll all benefit from, learning more about fibrinolysis. Thank you.
So thank you, Sandeep, and your talk definitely sheds the fear that anybody has, since it deals exclusively with indications, contraindications, after having made an established diagnosis of STEMI from the multitude of ECGs that you will see in Rajiv's and Chenniyappan's talk. I'm sure physicians across the country, once they are convinced that they are having a STEMI patient, they will thrombolize these people. Subhash Chandra's talk is going to tell you NSTEMI patients who do not need thrombolysis, but they are acute coronary syndrome patients nevertheless. So they do need antithrombotics. They need risk stratification, antiplatelet therapy. So how to distinguish NSTEMI from STEMI is very important. But once you made a diagnosis of STEMI, as Sandeep said, one form of fibrinolytic therapy needs to be instituted, and the faster you do, the better it is. The concomitant therapies, it's not just thrombolysis. Of course, thrombolysis is the definitive treatment, PCI or thrombolysis, but what additional drugs you need to use along with it have been covered by Shantanu Guha and Dr. Iyengar. In the third module, actually, we have covered pharmacoinvasive approach. We have covered complications of acute complications of actually STEMI. And then in the last module, post-MI patients, how to manage these. We are lucky we have a stalwart of Cardiological Society of India, the past president and a very close friend of mine, Dr. Mrinal Kanti Das. He has spoken on the long-term pharmacological management, which are in fact almost all the physicians. So this is actually a very important topic for physicians because you will need to treat post-MI patients on a long-term basis. So I'll request Dr. M.K. Das to share his thoughts on management of STEMI in India. The CSI has given guidelines on STEMI care in India, and then about his own talk also. Dr. M.K. Das, please.
So please unmute yourself.
Yeah.
Yeah.
Yeah, thank you very much, Dr. Wonder and the MKO team. I'm really proud that I have been associated with this very beautiful project. It's a fantastic project, in fact, because the knowledge and information that have been covered throughout the different modules will definitely enlighten all of the physicians and cardiologists. And though it might appear that they are being repeated, but definitely it will help the patients to a great extent. Now, already the diagnostic part and acute management part have been talked about. But very importantly, the long-term management of the patients is very much warranted, because the long-term complications or long-term what is called the MACE is very much important, and they are very high, in fact. What I have talked about the two groups of the MI, STEMI and non-STEMI, which have been actually classified into again two groups, that is the patients who have been managed without PCI or interventions or pharmacoinvasive therapeutic measure, and with PCI or what is commonly known as the percutaneous angioplasty. Now, what is very important to know in this group of patients is that there are different groups under the two groups of the patients. One is the ischemic group, and the other combination of the ischemic group and the bleeding risk group. So accordingly, it can be low risk, low ischemic risk and low bleeding risk. It can be high ischemic risk and low bleeding risk. It can be low ischemic risk and high bleeding risk. And in all this group of patients, they need to be managed with very, very utmost care, especially when you are dealing with the patients on long-term basis. Say, for example, high-risk patient with low bleeding risk patient, you'll have to continue the DAPT, or you may continue the DAPT for more than 12 months. And it can be continued up to even the 36 months. But when it comes to the low ischemic risk with high bleeding risk, then DAPT with the condition like atrial fibrillation on DAT or NOACs, they will need the therapeutic measure only up for about 1 to 3 months maximum. And thereafter, a single antiplatelet agent, and after that, of course, the only dual mechanisms of antithrombotic therapy, that is the NOAC, will have to be continued as a default strategy. Now, again, there are 5 groups of patients which have been talked about are 5 groups of drugs which have been talked about are ACEI, ARB, beta blockers, then MRA antagonists, statins, and antiplatelet agents, and last but not the least are some anti-inflammatory agents like colchicine and all. Now, what is important to know that most of the drugs, except the colchicine, are recommended with class 1 recommendation. So that must be remembered forever. Now, you might have to consider the dual antiplatelet agent as a class 2A or class 2B indication when there is high ischemic, moderate intensity ischemic severity with the high bleeding risk. So in those group of patients, you might be considering the dual mechanism of antithrombotic therapy or NOACs for longer period of time. Now, apart from this, on long-term basis, risk management is very, very important. And of course, you know that those group of patients who are not treated with the interventions, they might require interventions in the form of angioplasty at later point of time. And many a time, question is asked, how long the beta blocker should be used? Usually, the recommendation is that it should be used for about 2 years after the acute management has been done. And after that, of course, you can continue with the other therapeutic measures for about 3 years or so. So these are, in fact, some of the important information we have shared, and I'm sure these are going to help our patients on long-term basis.
Thank you, sir, for sparing your very valuable time and shedding great light on actually your talk. I was listening to it. It's a beautiful talk which touches upon the nuances of how long to use DAPT, use RAS blockers, statins, as he said, beta blockers. So in an excellent lecture, sir has covered all the aspects of how a physician should be treating actually a post-MI. And as you rightly said, risk stratification, it's not just these drugs. Continuous risk stratification of these patients is equally important on a long-term basis because some of these patients can have complications. And I am happy to actually share with you, my colleague, Dr. Abhishek Goyal is also with us. And he has covered the post-MI arrhythmia group. He is actually has keen interest in EP, but he performs most of the primary PCIs. Today he said he had fever, so one of the primary PCI he asked me to do, but a lot of our primary PCI load 24/7 is now handled by Abhishek. So Abhishek, let's listen from you. What are your thoughts on post-MI arrhythmias? Because these take away a lot of our patients, even when we have done an excellent job, the role of drugs and devices. Dr. Abhishek Goyal, please.
Thank you, sir, for kind words. A very good evening to all. My sincerest regards to once again Dr. Wander and all the senior most physicians of the country. It's my privilege to be part of this great initiative. Dr. Wander had given me the responsibility to cover post-MI arrhythmias. As we know that post-MI arrhythmias can range from benign arrhythmias to malignant arrhythmias like ventricular tachycardias. So it's very important for the physician to recognize what arrhythmias are benign, what arrhythmias are malignant. For example, initially it was said that accelerated idioventricular rhythm, some people can mistake it for ventricular tachycardia, whereas it is a benign rhythm. Similarly, if you have to make a correct diagnosis of ventricular tachycardia, because if you miss this tachycardia can be life-threatening. At times, you have subsets where ventricular tachycardia can be recurrent. So the management of these arrhythmias can range from very basic maneuvers like beta blockers, use of amide or lignocaine, to use of advanced form of therapies like overdrive pacing and use of other drugs such as quinidine. Very often we require a stellate ganglion blockade for management of our arrhythmias. Well, these things physicians should be aware of, because it is not infrequent to have post-MI patients who land up in VT storm. So just relying upon beta blockers and amiodarone sometimes may not be fruitful for your patient. So that's one point which is very important in management of ventricular tachycardia. Second is, it is very important to categorize ventricular tachycardias into primary and secondary ventricular tachycardias. Secondary ventricular tachycardias are basically which are occurring after 48 hours of MI, because these are the patients who are at higher risk of sudden cardiac death on follow-up. And physicians should know that these patients, they need to be referred for AICD, because beta blockers and other drugs, they are not going to prevent unfortunate mortality in these patients. So I think the physician's responsibility in management of myocardial infarction is very wholesome, right from correct ECG diagnosis of myocardial infarction to thrombolysis to management of post-MI arrhythmias, and then identifying the patients who are going to benefit from AICD device. Physicians must be well aware of all these things, and I've tried to cover all these things in detail. Thank you all, and thank you, Dr. Wonder, for this opportunity.
Thank you, Abhishek, for highlighting the value of ICD devices in patients with large infarct, low EFs, and as you said, secondary, at least the secondary prevention group must be given ICD in even in a resource deprived situation, because it certainly saves many lives. Besides these two excellent lectures by Dr. M.K. Das and Dr. Abhishek Goyal, we also have Dr. Sirish Sathe's talk, and Dr. George Koshi from Trivandrum has spoken on how you can set up a thrombolytic program in your institution. So we are lucky we have although we are just reversing a little bit. The last, I will request Dr. Uday Jadhav to speak on his topic and tell us. He's just joined a little late, although he is the opening batsman for us and has spoken on how to interpret chest pain as for diagnosis, because as you know, this is the first step. So Dr. Uday Jadhav, and then we are going to actually share with you, all the delegates, a short demo in the next 10 minutes on from the portal developer as to how you can log in and how you will be logging into various talks, and then we will end. So over to Dr. Uday Jadhav, and then blessings from Dr. Rajasekhar, and then we will actually have this short 5 to 7 minutes demo on portal opening. Dr. Jadhav, please. Are you there, Dr. Uday Jadhav? So I believe he is not there. So let's have Dr. Rajasekhar's blessings in the end on behalf of the Physician Research Foundation, and then we can have the portal. Dr. Rajasekhar, please.
Good evening, Dr. Wander. Thank you very much for inviting me. This is a very good program. So the history is very vital, then the ECG, and last but not least, the biomarkers. So all these three things are the basics, and then how to manage earliest. That is very important. So we must train the primary care physicians appropriately, and also the thrombolysis, the door to needle, and what is the time and all. So I think this is a very useful and very good initiative. Thank you, Dr. Wanderji, and all the guest speakers. Thank you.
Thank you. I'll request our academic partners, Hamcc, to share their thoughts, and to thank all the physicians across the country who have logged in, and then maybe we can have the portal sharing methods.
Sir. Sir, on behalf of Hamcc, I am Dr. Ronak, and I would extend my heartfelt gratitude to everyone for joining in for this launch of Heart Attack Management Certification course, which is of course in collaboration with API, making it a significant milestone in advancing cardiac care in India. In India, we are aware that timely access to PCI for STEMI patients remains a challenge due to geographical and socio-economic barriers, making thrombolysis a crucial yet underutilized therapy. So with increasing awareness and adoption of thrombolysis, it can save a lot of lives. And Hamcc has been at the forefront in this space for over 2 decades now, introducing advanced thrombolytic therapies to ensure timely and effective treatment. So we really thank Dr. G.S. Wander for his invaluable leadership in shaping this comprehensive program. Of course, API for their unwavering support, and all the distinguished speakers who have contributed to the 4 modules and 16 lectures, enriching the course with their expertise. A special appreciation to all the MCure team as well for their dedication in making this launch possible. And thank you all the 1,000 plus delegates for their enthusiasm and commitment to enhancing cardiac management. Your dedication to improving patient care is truly inspiring, and I'm sure that together we can make a meaningful impact in the fight against heart disease. So thank you so much. I would request Hardeep now to just take us through the portal, and we can disperse then. Hardeep, over to you.
Hello everyone. My name is Hardeep. I am a developer of this web portal. I will share my screen. I hope you can see my screen.
Yes.
Yes.
Now, in the first page, we have a 2 options, login and register. If I am new, I have to register myself first. Here is the detail. Once a register is done, I will try to log in. As you can see, I can enter email ID or UID to log in and password. I already have a demo user, so I will try to log in. Here, after the login, you can see here the dashboard is the first page. I hope you can see it. Now, I will start quiz. Once user complete the video, he will click on the start quiz. Here's the first chapter MCQ. I will click on randomly and save and continue. Is the next chapter, and you can see is second video. And I will start second chapter and I will click randomly any option. So I have no idea which is right option or wrong. Save and continue, and is chapter 3. Now same thing, I will click on start. Simply I will continue. So I have to wait few seconds. No, it's open my third chapter. I will click randomly any option and save and continue. It will go to my fourth chapter video. You can see is fourth chapter and start the quiz for fourth chapter. MCQ started. I will click on any option. So here is finish my first module. So please tell me, should I complete all module?
It's okay, Hardeep. I think we've done a great job you have done. I have listened to all the talks and it is very user friendly. It is very easy to browse through the various lectures. You can go back, you can answer the quiz. If there are score is less, you can go back to the talk and you can again attempt those questions. So before I say my formal thanks to each one of you, all the faculty members, especially to Dr. M.K. Das sir, Rajiv Agarwal, Abhishek, and Dr. Devabrata Roy, all of you who have spared your Sandeep was here. So all of you actually who have spared your valuable time and also excellent lectures that you all have given. Thank you very much. And maybe we can have the last word from MCure before we say goodbye.
Right. So thank you so much, everyone, for joining in today. And I hope that this program will enrich everybody's clinical expertise going ahead. Thank you so much, everyone, and have a good evening.
Thank you.
Thank you.
Thank you, sir.
Good evening, everyone. Devabrata, how are you? Thanks, everyone. Bye.
Thank you,
Bye.
Dr. Das, sir. Thank you, Dr. Ramanathan, sir. Thank you all.
Recording stopped.